Good evening, and thank you for joining the NANS Education Committee webinar, Dorsal Root Ganglion Stimulation, Understanding DRG Targets and Theory. My name is Darren Wilson. I'm an interventional pain management anesthesiologist. I practice in Indianapolis with Goodman Campbell Brain and Spine. I've been fortunate to be involved with the teaching of DRG stimulation since it was brought to the market in the US in 2016. Tonight's webinar will be focused on the foundational concepts of DRG stimulation. The intended audience is residents, fellows, advanced practice providers, or physicians in practice that may still have some questions regarding DRG stimulation. We were originally scheduled to have Magdalena join us for tonight's discussion, but unfortunately, she is indisposed and will not be able to join us. Fortunately, we're joined by two young innovators. Dr. Bartholomew Liebau is originally from the Burgundy region of France, where he completed his undergraduate work in medical school. He completed his PM&R training at the State University of New York and recently finished his fellowship in interventional pain management at the Spine and Pain Institute of New York. Welcome, and thank you for being with us, Dr. Liebau.
Thank you very much for the introduction, Dr. Wilson. Pleasure being here tonight.
Dr. Thomas Shaw is currently both an assistant professor of anesthesiology at the University of Chicago and a fellow in interventional pain management. He did his undergraduate training at Princeton, medical training at University of Virginia, and his residency training at the University of Chicago. Welcome, and thank you for being with us, Dr. Shaw.
Thanks very much for having me, Dr. Wilson. Glad to be here.
Dr. Shaw is going to start with a presentation on the fundamentals of DRG anatomy and why we should consider targeting the DRG with neuromodulation. Dr. Liebau will follow up with a discussion on determining the appropriate levels to target for specific diagnoses and pain conditions. We'll have a brief discussion regarding the safety of DRG stimulation, followed by a group discussion on the importance and potential roadblocks of implementing DRG stimulation into your practice. Some quick housekeeping. On the right side, you should see a control panel, and near the bottom, there is a chat box. Please feel free to submit any questions you may have as we move throughout the presentation tonight, and we'll hopefully be able to address your questions at the end. Before we get started, I'd like to ask both of you a quick question. You have both been fortunate to be exposed to DRG stimulation in your fellowship. What do you believe was the biggest roadblock or issue you faced as you initially learned DRG stimulation? Dr. Liebau, let's start with you.
I think it's just a bit scary at first. It's technically more challenging, I feel, at least at the beginning. I think that would be the initial roadblock for me.
Well, thank you for your insight. And you, Dr. Shaw?
I echo that. Certainly, the technical aspect of it is a little bit more challenging. And I also found initially it was kind of a question of patient selection, who would be an appropriate candidate for DRG versus more traditional neuromodulation.
Well, I've been fortunate to teach thousands of folks DRG, and your sentiments are right on par with most. Typically, DRG stimulation has faced a few misconceptions. It's viewed as too difficult. It's viewed as unnecessary, as you can get similar results with other technology, or it carries too much risk. After tonight, I believe you will have the knowledge to be able to evaluate for yourself the validity of those misconceptions. With that, I'm pleased to turn it over to Dr. Shaw.
Thanks very much. Let me just make sure my mouse is working. All right, perfect. So I'll begin the presentation by giving just a brief and kind of 30,000 feet perspective overview of relevant aspects of DRG anatomy. And throughout, I'll try to provide some not only anatomic, but also electrophysiologic and kind of neurohormonal pearls to illustrate how we arrived at this concept of targeting the dorsal root ganglia for neuromodulation. Trying to progress to the next slide. I apologize. Okay. So just a brief overview of 5 major points I'll talk about. First, we'll talk about the predictable location of the DRG from an anatomic perspective. We'll talk about the function of the DRG in normal cells as a low-pass filter, allowing for kind of intrinsic modulation of pain signals passing into the central nervous system. We'll talk about the role of glial cells and surrounding inflammation in the development of chronic pain states. We'll then talk about the hyperexcitability associated with chronic pain states in neural cells. And finally, we'll briefly touch upon how to leverage dermatomal patterns to allow pretty exquisite targeting of relevant areas of the body. So to begin, we have to go way back 22 years ago to the year 2000. Kemmler and his colleagues published a study in the New England Journal of Medicine showing that traditional spinal cord stimulation, or dorsal column spinal cord stimulation, achieved about 50% pain relief in 50% of patients in the sample size of CRPS. Obviously, this was a foundational work, again, published in the New England Journal, and it showed the potential of neuromodulation as a way to treat focal areas of chronic pain. And as I'll attempt to show through the next couple of slides, the development of DRG targeted stimulation is a logical and perhaps inevitable outcome of the original work that Kemmler done 22 years ago. And in fact, a possible explanation for why there was that 50% response rate is the fact that in certain peripheral nerve damage associated pain states like CRPS, the pathology is actually located in the DRG itself, not the dorsal columns and not the peripheral nerves. And by way of summary, this is a simple cartoon that everybody has seen of pain transmission pathways. So we can see nerve endings associated with peripheral nerves going into the dorsal horn of the spinal cord by way of the DRG. These tracks then ascend via the dorsal columns, initially going into the medulla, then the thalamus, then eventually the primary somatosensory cortex. Zooming in a little bit more at the dorsal horn and the spinal nerves, through fairly elegant lesion studies, we can start to see the important role that the DRG plays in chronic pain states. So here we're looking at action potential tracings from a recording electrode placed just dorsal to the dorsal horn, here denoted by the R in the gray square. And we can see that transecting the spinal nerve, as indicated by number 1, really has no effect on action potential propagation into the dorsal horn, as shown by the essentially lack of change at the recording electrode. However, if we were to transect proximal to the DRG at point 2 right here, we see not only a significant decrease in amplitude, but also a significant decrease in frequency of signals making their way into the dorsal horn. And this is the fundamental reason why a system was created to access the DRG. Let me try to go back one slide. We can see by these lesion studies that, again, the pathology is not in the dorsal columns that we can target with traditional spinal cord stimulation. And it's also not in the peripheral nerves that we can target with peripheral nerve stimulation. The pathology is actually located in the dorsal ganglia itself. From a purely anatomic perspective, the dorsal ganglia, from an anatomically, are located in a fairly simple area. Essentially, the relevant and corresponding DRG is located just inferior to the corresponding bony pedicle. So here on screen right, we see a lateral view of the lumbar spinal column. The top vertebra is L3, and so we can see that the L3 DRG exits just inferior to the L3 pedicle. One other important aspect to remember regarding the dorsal root ganglia is that they are actually still located within the epidural space. The implication of this is that we can access the DRG via traditional methods of accessing the epidural space. This is shown a little bit more clearly in this purely axial cut. Here we see a 4-lead electrode array. The electrode array itself is placed posterior to the ganglia. But again, we can see that the way we actually enter into the space around the ganglia is through the epidural space, which again, we can access via traditional epidural methods. One aspect from an electrophysiologic component that I'd like to touch upon regarding DRG anatomy is their potential function as a low-pass filter, thereby allowing for a certain amount of intrinsic modulation of pain signals. So DRG neurons are pseudo-unipolar neurons. What this means is that the cell body is connected to the axon via a small T junction, as we can see in the lower illustration here. By way of reference, the top neuron is a bipolar neuron. Again, DRG neurons are pseudo-unipolar neurons with a T junction connecting the cell body to the axon. What this allows is for the cell body to modulate signals passing through the axon from the periphery into the central nervous system. And essentially 3 patterns of signal modulation are possible. Looking on screen right, we can see that one method of signal modulation is complete blockage of action potentials. So we see action potentials coming in from the periphery, interacting with the DRG, which disallows any signals from propagating further into the dorsal horn. The DRG could also function in essentially a non-functional way by allowing all action potentials to pass through into the central cord, as shown here in the lower panel. Alternatively, and finally, the DRG nerve body can function as what we call a low-pass filter. Essentially what this means is that DRG nerve bodies, they have an intrinsic threshold action potential frequency rate. Any action potentials that enter the DRG at a lower frequency than threshold are allowed to pass through unchanged and unabated. However, any action potentials entering the DRG at a higher frequency than threshold are only allowed to pass through with a decrease in amplitude and a decrease in frequency. And so this is what we mean by the DRG potentially functioning as a low-pass filter for action potentials traversing from the periphery into the dorsal columns. This was a fairly elegant study showing that essentially direct stimulation of a DRG-associated nerve body not only leads to significantly decreased amplitude, but also decreased frequency of action potentials that are allowed to enter into the dorsal horn. We also need to remember, however, that the dorsal root ganglia, they don't exist in isolation. Like all nerve cells and bodies in the body, the dorsal root ganglia are surrounded by glial cells. And essentially what happens is it's a combination of electrical and neurohormonal feedback loops that could potentially lead to the development of chronic pain states. And so the putative mechanism is a peripheral nerve injury that first results in increased electronic neural discharge from primary sensory neurons. This in turn leads to the release of excitatory amino acids, nitric oxide, and neuropeptides. What these peptides and compounds do in turn is they activate the surrounding glial cells, the astrocytes, etc. And these glial cells in turn release pro-inflammatory cytokines. And so you have this inflammatory soup surrounding the DRG that in turn stimulates the neurons further, increases membrane excitability, and decreases stimulation threshold. One important point to touch upon is this idea of a decreased stimulation threshold in chronic pain states. This was an exceptionally elegant study done by Rush et al., which essentially showed in a rat model that in chronic pain states, the DRGs are hyperexcitable from an electronic standpoint. Here in panel A, we see action potential tracings from wild type mice, normal mice with normal functioning dorsal root ganglia. Of note, I will point out that the resting membrane potential of this DRG is about -50 millivolts. and the threshold for action potential propagation is about 130, 135 picoamps. What the experimenters then did was they recorded action potential tracings from mice who had a lesion in a sodium channel that's associated with a chronic neuropathic pain state called erythromyalgia, which is commonly associated with burning pain, mostly in the hands, but also in the feet. Specifically, this was a substitution of a leucine for a histidine, 0.858 in the sodium channel. And so these are mice that demonstrated chronic pain states. And we can see in the action potential tracings in the lesion mice, not only is the resting memory potential higher, in this case about -45, -50, but the threshold for action potential propagation has significantly decreased from about 130 in wild type mice to about 60 picoamps in the lesion mice. And so to summarize on screen right, essentially what we see is in mice with chronic pain-associated sodium channel lesions, the threshold for action potential firing is significantly decreased in the DRG. And finally, I'd like to touch upon briefly the ability of the DRG to be mapped to very specific dermatomes and in turn very specific anatomic areas of the body. Here we see the classic dermatomal map that we're all familiar with from medical school. And as a historical reference, they started doing work in this in the 1800s. Essentially, patients with central spinal cord lesions had associated sensory deficits that eventually were carefully mapped out into this dermatomal map that we are well familiar with. And the fundamental point here is that DRGs map specifically to these established dermatomes. By way of example, let's say we wanted to stimulate the DRG for right-sided foot pain. If we were to target right-sided foot pain with traditional dorsal column spinal cord stimulation, we would place a lead generally in the low thoracic space, anywhere from around T8 to T11. And stimulation there would certainly target the right foot, but it would also lead to stimulation of unwanted, unpainful areas. What the DRG allows us to do is more specifically target that right-sided foot. If we were to thread a DRG lead to the right-sided L5 DRG, we would be able to stimulate the L5 dermatome and the L5 dermatome only, essentially modulating the sensory fibers from L5 prior to them entering the dorsal columns and ascending. And again, this just illustrates that the DRGs are organized into classic dermatomal patterns. For example, if we wanted to target peri-umbilical abdominal pain via DRG, we could target the T10 DRG. And if we wanted to target pelvic floor pain with the DRG, we could target the S2 DRG. And so to summarize, DRGs are located in a very predictable anatomic position. They exit just dorsal to the spinal cord. They sit underneath the associated bony pedicle, and they lie within the epidural space, allowing easy access to the DRG via classic epidural methods. Functionally, in normal DRGs, they function as low-pass filters, allowing for a certain amount of intrinsic modulation of pain signals. DRGs do not exist in isolation. They are surrounded by glial cells, which through inflammatory cytokines and other mediators can hasten the development of chronic pain states. This inflammatory mediation decreases threshold firing potentials and renders diseased DRGs hyperexcitable. And finally, DRGs can be targeted quite precisely to specific dermatomes of the body.
Tom, that was phenomenal. Well done. That's a lot of information. And quite frankly, you made it seem easy. For those that may not have been able to take it all in, is there one item, is there one takeaway in terms of your portion, the anatomy portion, that you'd recommend that they wouldn't forget?
I think one important aspect is the fact that the DRG is still located in the epidural space. And so from a technical perspective, we access the back in the same exact way that we would do with a traditional dorsal column spinal cord stim lead.
I certainly don't disagree. It's a phenomenal technique. and it's not as hard as most people make it out to be. I think my takeaway, honestly, is the DRG is the source of pathology for a lot of neuropathic conditions. And if we can modulate the source, outcomes just surely have to come along for the ride.
Absolutely.
With that, we're going to move on to Dr. Leobau. You are going to enlighten us on DRG targets.
Yes, thank you very much. So I have the mouse now. I'll try to do my best. It's just really a great review of anatomy. Here we are. So just quickly, I know that Dr. Shao talked about it, but since Melzack and Wall gate theory described in 1965, the first spinal cord stimulator, dorsal column, was invented in 1968. The DRG STIM proof of concept was in 2009, authorized in Europe in 2011, and in the US in 2016. I'm saying that because I'm going to present 6 papers which have been written. Half of them are from Europe because they're five years ahead of us. And lots of them have few patients because, once again, it's a newer technology. So I just wanted to clarify that. So, I mean, despite the overall success of a spinal cord stimulator in treating like a lot of neuropathic pain conditions, focal pain conditions such as CRPS, phantom limb pain, injury or disease of the peripheral nervous system have created challenges for the efficiency of the dorsal column stimulator. Focal areas of pain such as the trunk, groin, knee, foot, hands, and the sacral areas have not always been captured reliably by the spinal cord stimulator, creating unwanted paresthesias or failure to provide relief. And if you look at the literature, there was multiple paper reports that the rate of spinal cord stimulator system removal is as high as 23.5%, and half of those removal are for therapy failure. So initially, the spinal cord stimulator was approved for failed back syndromes, peripheral vascular disease, angina pectoris, CRPS type 1. And now that the DRG is here, it's taking more and more space in area of treatment that the dorsal column stimulator was prevalent. Like as you see on the picture here, CRPS type 1, all the peripheral neuropathy, chronic low back pain, non-surgical back pain, and now even surgical back pain are being eaten by the DRG stimulator. And specific things, all the post-amputation of the extremities are targeted by DRG and unreachable by dorsal column stimulator. So, oops, sorry. The first paper I'm going to talk about is has been written by the Neuromodulation Appropriateness Consensus Committee, led by Tim Deere, and to which Dr. Wilson participated. And basically, one of the major differences between DRG STIM and traditional SCS is the ability to offer targeted stimulation of distinct areas of the body by modulating focal areas of the spinal cord rather than like sticking leads on the back of the spine and stimulating multiple levels, which you do with the dorsal column stimulator. And also, as Dr. Chow mentioned earlier, you may choose intuitively to target the level most closely corresponding to the dermatome where the pain is located. However, in cases of severe deafferentiation or central sensitization, like post-amputation pain, for instance, the pain may not conform to basic dermatomal patterns, meaning that the pain that would appear to be the L5 dermatome may not respond to a lead placed over the L5 DRG. So that presents a potential dilemma for the DRG-led placement. So that's why this chart is showing that suggested levels of stimulation by pain location. So the data were compiled from a poll of the authors of this paper, which are multiple, as I mentioned earlier. And the area of the circle in the middle of the chart represents the number of implanters recommending each level. For instance, if you look at the groin, if you want to target the groin, you may place leads at T12, L1, or L2, or place leads at all 3 levels. It all depends on how the patient responds and how the trial goes. Same thing with the hip. L1 and L2 are the two most prevalent levels of stimulation. So that was very interesting. So this chart is very interesting. If you want to start implanting DRG, you would refer to that a lot. I did in fellowship prepping for cases. I would look at that and before going to assist in DRG implantation. So this paper also shows that the group for which there is the highest level of evidence are those patients with CRPS type 1, type 2, and also the chronic post-surgical pain, which is a type of CRPS type 2. And so the NAC, which is the Neuromodulation Appropriateness Consensus Committee, sorry for my French accent, it's kind of hard, said that for those patients, the DRG should be the primary treatment solution before spinal cord stimulator, before other things like that. And it's a level 1 evidence, grade A, so it's very strong consensus, especially if the lesion, if the pain is towards the extremity or in the pelvic area. Now there's another paper. The next paper I'm going to talk about is talking about hernia pain. So it's kind of a CRPS type 2-ish because there's a clear lesion of the nerve, as opposed to CRPS type 1, which is a trauma with no clear nerve lesion, but the same symptomatology. So in the US, there's more than 1 million hernia repairs a year. 800,000 are inguinal hernia repair. 5 to 15% of those will develop a postoperative pain syndrome, and about 3 to 5% will develop chronic pain, which is like 40,000 patients a year. So as you see here on the picture, the groin is primarily innervated by the ilioinguinal, iliohypogastric, and the genitofemoral nerves, which enter by the spinal foramen at the level of L1 for the ilioinguinal and iliohypogastric, and L2 for the genitofemoral. From there, those spinal nerves enter the spinal cord at about the level of T11, T12 vertebra. So, Jesus, this mouse. So this paper is coming from Germany. It's by Morgella and all. They wanted to see if the DRG provide long-term relief of chronic groin pain over a period of more than 3 years. So they did that from March 2012 until March 2016, enrolled 34 consecutive patients who all underwent trial, 4 dropped out, leaving 30 patients, of which 11 were followed all the way to 3 years. So those patients were specifically treated for chronic neuropathic pain in the groin using DRG stimulation. They were moving from trial to implant if the pain relief was at least 50%. And the follow-up was 3 months, 1, 2, and 3 years. And as you can see on the chart, most of the patients were implanted at L1 and L2 levels, as we saw on the previous chart. A few of them were L1, L2 only, T12, L1, or T12, L1, L2. So the takeaway from that is that at 3 months, the average pain reduction was 75%, and 83% of the patients had 50% or more of relief, which is gigantic. At 3 years, the average pain reduction was still 63.5, and 72.7, which is 73% of the patient, had 50% or more pain relief, which is extremely efficient compared to spinal cord stimulator. When I say that, I mean dorsal column stimulator. So basically, this paper shows that the DRG is an effective long-term treatment for chronic groin pain if you place the lead at L1, L2. All right, so that's another paper, pretty much the same thing, coming from 2015, showing that the use of DRG stimulation for difficult to treat conditions like groin pain. So it's only 29 patients across 11 European centers, another European study. Of those patients, 12 had hernia repair, 9 had a positive trial, 3 didn't. So basically 25 of those patients got implanted. And the same thing, they obtained like similar results as the one previously obtained by Margella. So as opposed to Margella, the follow-up was only 7 months on average, which is not as long. But 83% of the patients had at least 50% relief, 50% improvement in their pain score, if you will. 50% had more than 80% improvement, which is huge. So the mean pain reduction at the end of the follow-up after 7 months was 71.4%. So it really worked for this patient with groin pain. All right, and so that's, sorry, my thing is, so that's another study by Hunter and Young, an American study, looking at case series of pelvic pain, chronic pelvic pain, which is also a gamut of patients that are not helped by anything. And DRG stimulator for those type of patients is very efficient. So basically, chronic pain is chronic pelvic pain, sorry, is an elusive and very complex condition with a high socioeconomic burden, really. It affects both men and women, and patients have a very hard time talking about it. The prevalence is estimated at 40% of the population, which is huge in the US. The annual healthcare cost related to that in women alone approach nearly $3 billion per year. So in this study by Hunter and Young, there are 7 patients, 4 females, 3 males, with a 12-month follow-up max. So basically, they followed with 7 patients. We tried everything: medication, neurolysis, surgery, spinal cord stimulator, and the pain was located, in or out of vagina, anus, a glans of penis, left perineum, left buttock, pubis, saddle, everything. And so, as you see on the chart, like it's a follow-up of the 7 patients. Only 4 were implanted, because the trial was very successful. The 3 others in the paper were pending implantation, but they also had a very successful trial. So and they targeted L1 and S2. So the story behind that is like stimulating the L1 DRG, according to them and according to the theory that people have at this time. If you stimulate the L1 DRG efficiently, you efficiently modulate the pain signal carried by the upper portion of the lumbar plexus, ilioinguinal, iliohypogastric, and genitofemoral nerves at L1, L2. And more importantly, L1 is the most cephalad segment where pain signal from below L2 could make the transition to continue to propagate into the brain via the Ramayé communicants. So it's really a gatekeeper. So basically, modulating L1 DRG fundamentally closes the gate pretty much to pain. And similarly, if you stimulate the S2 DRG, you interrupt signals from the lower portion of the lumbar plexus, L5, S1, the entire sacral plexus at S2, S3, and this should provide enough coverage to disrupt the afferent input from the foot, the toes, as well as pelvic pain originating from the pudendal nerve or the sacrosplanchnic sympathetic plexus. So L1 and S2 would cover pretty much the whole pelvic area. And the study by Hunter and Yang, even though it's only 7 patients, shows that it's very efficient. So another study shows how the DRG is efficient for peripheral nerves as well. Like if you look at a knee replacement, at best, people will have numbness of the knee. At worst, they will have neuropathic pain. And you can see on the drawing here that the branch of the saphenous nerves are unpredictable and cover the whole knee. So it's impossible to avoid them when you undergo surgery, right? So I don't know. I'm sorry that the mouse is extremely sensitive. So this study, another study by Morgella, our friend from Germany, he had like 62 patients with multiple pain at the periphery. So there was like foot pain, there was like knee pain, mostly knee pain. He enrolled patients from March 2012 to March 2016. 27 women to 34 men. They all underwent trial. 11 dropped out, leaving 51 patients, of which 55 were followed up to 3 years. So the majority of the patients presented with knee pain, 30 patients, but also other localized pain, as you can see here, in the foot, the hand, the back, the legs, and you can see the level to which they were implanted. For the knee, L3, L4, for the foot, L5, S1, and the hand, as you see, but it's more anecdotal because there's not that many patients for other locations. So as you see here, the results, the pain decreased tremendously at 1 year, 2 years, and 3 years. Especially for the knee, you see like the VAS initially for the 27 patients, the VAS was 8.9. At 1 year, with the 25 patients who followed, the improvement was 79%, meaning that the pain score was not even 2. At 3 years, with the 16 patients who were present for the study, the percentage of improvement was still 69.2, which is like slightly above 2 on the VAS, which is really, really impressive, honestly. So roughly 71% of the patients reduced or completely stopped pain medication, which is also quite impressive. And it lasts, which is very, very good. And this last study, I promise after that we're done, it's coming from Eldab et al. It's a patient who tried the DRG stimulator for phantom pain syndrome after amputation. So it's only 8 patients, and it's a retrospective study. But those patients were trialed with DRG between 2012 and 2013, with 5 to 24 months of follow-up. And at baseline, as you see here, the average VAS was 83.5 millimeters. And at the last follow-up, the average VAS was 38.9, which is on average 52% reduction, which is huge. And out of those 8 patients, 3 were not satisfied. 1 had no pain at all, and the others had at least 50% of pain reduction. So those are all the patients I mentioned, all the studies I mentioned are patients who will fail anything else but DRG. Based on my history, based on literature, we need more literature. We need more studies, and there's a lot of study going on which will show that the DRG is really a product of the future, I think, for neuromodulation.
Well, Bart, both you and Tom have knocked it out of the park. I know it's a U.S. analogy, so I guess football would be your national sport. I'm not sure what the analogy is, but you did a good job. So I personally love your French accent, and it's only fitting, given that the vast majority of our data comes from Europe, kind of as you described. One quick question for you, Bart. You trained with Kieran Patel, Ken Chapman, among others, and I know them well, and I believe they believe that every patient that's a candidate for neuromodulation is in fact a candidate for DRG stimulation. I've had fantastic results like you described with pelvic pain, with posterior neuropathy pain. In my practice, it has its role, but it's not all my patients. So how are you going to reconcile what you just learned over this last year in New York, and how do you see DRG stimulation fitting into your practice?
So I do think, as you said, I was trained with Dr. Patel and Dr. Chapman, who are really implanting DRG a lot and very successfully, might I add. So it's true that for me, if you think of placing a dorsal column stimulator, why not place a DRG, right? So I think that I'm going to probably make my own mind when I'm facing a patient by myself. I don't have my attendings behind me. But so far, listen, even for peripheral nerve, like we did some DRG for knee pain, it's extremely promising. So, I think I'm going to be more aggressive with DRG than people think I would. That's my take. Once again, I'm still a baby in the field, so.
Well, coming from your program, I wouldn't expect anything less. I'm going to transition. Before we transition, I'm going to actually address a question since you brought it up, Bart, but I'm going to direct it to you, Tom. So online, we have a question. How would you decide whether to place a DRG stimulator versus a PNS stimulator?
I think fundamentally, the answer to that question resides in the anatomic correlate that we talked about. For a lot of these pain states, you can make the argument that the pathology is actually in the DRG itself as opposed to the peripheral nerve or the dorsal columns. So depending on the pathology, I think there is a strong argument to be made for more directly targeting the DRG, which in a lot of chronic pain states, it's the actual site of the pathology.
I wouldn't disagree. I think it's a good corollary to a good board answer, and the answer is it depends. There are cases for PNS. Shoulder pain just comes to mind. I think I would lean towards that over DRG in that scenario, but I really think it depends on the circumstances and the patients that Bart just eloquently described. Outside of knee pain, there's probably some overlap there, but outside of knee pain, all the patients he described in those studies, in my experience, do better with DRG stimulation than any other neuromodulation technique that we currently have on the market. So with that, I would like to transition over to safety, and I need control of the slides. So we've kind of touched on a couple of the pillars, misconceptions I described earlier. One of the fundamental reasons why I've asked Tom and Bart to be involved tonight is really kind of demonstrate that this isn't too difficult. Conceptually, they've demonstrated a superior amount of knowledge, at least on the science behind this, the patient selection. Technique aside, which we certainly can't address in a webinar, they have already been able to master that portion, which is a big part of it. One of the other fundamental issues, misconception, I believe, is that DRG just isn't safe. As Tom alluded, this is a traditional epidural access. But Dr. Deere and al., who published this in Neuromodulation back in 2019, really kind of dove in and looked at it systematically. And really, they're trying to evaluate the safety and efficacy of DRG stimulation. They looked at all the complaint records on DRG and traditional spinal cord stimulation, dorsal column stimulation, were obtained from the manufacturer, and they were analyzed and compiled. That data was stratified according to the type and was also compared to the literature and to also other neurostimulation techniques from the same time period. So if we look at simple graph of the majority of the data, there are some common complications that come to mind if we're talking about stimulation, and ones that you might conceptually believe that DRG may be a little bit more risk prone than traditional stimulation. With that might be CSF leaks, maybe hematomas, potentially loss of motor muscle control. And if you look at the data, although the DRG stimulation is slightly higher, it's statistically not a significant amount, at least in my opinion. So if you look at the overall data, looking at all those categories, the incidence of complication with traditional stimulation, dorsal column stimulation was 3.09. If you look at DRG stimulation, it was 3.24. So very comparable. If we look at the things that really matter, CSF leaks, infection, and implant pain, and we compare those with the published rates of complications, as well as if we compare them with alternatives. So one of the drawbacks, one of the misconceptions is you can get similar results placing a traditional stem in the gutter. But if we look at all four of those, really what we see is that traditional stimulation and DRG are extremely safe, and they're very comparable, and they're safer than trying to utilize the wrong equipment for the wrong job. And comparing it to the published data, DRG stimulation is well within that framework. So with that, we're going to kind of transition to some discussions. So I'm going to start with you, Tom. So what obstacles can you anticipate as you transition into your own practice when it comes to implementing DRG?
I think number one, it is, despite the fact that you can certainly access the DRG epidurally, it is a little bit more technically demanding than a traditional stim. And as I'm envisioning my practice free from the chains of training, you know, I do anticipate potentially having a little bit more, I'll put it this way, I would like a little bit more experience while I'm a fellow placing additional leads so that I get that technical comfort level with threading the leads laterally. Other than that, it's the same question as always, you know, which patients would be most appropriate for DRG stimulation versus the other modalities we talked about?
I would agree, and I think Bart represents the minority in folks coming out of fellowship with the experience that he has. So don't feel bad about your experience. University of Chicago is sound. You'll be fine. It just takes some patience to kind of get there. So Bart, do you see any different challenges that you might face?
No, I mean, I do agree with Tom. It is, I mean, if you start a new practice, you need to build the referral to have patients who would benefit from DRG. You need to see enough patients to be like, you know, we tried everything, let's do DRG. And I think thirdly, I would start putting DRG in the cases that really need DRG. You know, pelvic pain seems like straight shoot to L1S2. You know what a pelvic pain is. Most of the patients come here and they tried everything. So you're their last hope. And I think those patients are hard to manage because they are difficult patients most of the time, but you can help them tremendously. And also for low back pain, which same thing, they tried everything, they've done multiple injections. To place the DRG at T12 and S1 does miracle as well. So I wouldn't be like too crazy. I wouldn't do any cervical DRG. Like as Dr. Deere says, you need to do like at least 100 normal DRG before even trying to place something in the neck. I agree with him. But yeah, I think that's what Tom was saying.
Well, I would agree with every modality, patient selection is the key. But with that said, if you don't have this in your tool belt, you're never going to use it. So I think there's some value in understanding where this does apply. And I think it's of value to be persistent and stubborn and kind of work through some of those obstacles. Tom, I'll tell you, once you get comfortable and experienced with this, it doesn't take any longer to do DRG stimulation than it does to do traditional spinal cord stimulation, but it just takes some time. But yeah, I appreciate your frankness. So we're going to look at a couple questions that people have submitted online. Thank you. Annette is being very forthcoming, so I appreciate that. So her question was, how long does DRG stimulator catheter stay in for? I know she means the lead itself, but so to clarify, Annette, so DRG stimulation is very similar to traditional stimulation in that there's a trial and a perm phase, and that varies depending on location, setup, and how it's implanted. It's different in the US versus Europe. In the US, we typically will put in a DRG trial lead for days, and that could be 3 to 14. I think average would probably be in the 6 or 7 range. And then the trial lead typically comes out, and then we re-implant it during the permanent phase. There are those that would stage this and put in the leads surgically and have extensions. But at least in the US, the majority of the cases are done as a PERC trial. Leads come out after a week or so, and then the permanent is adjusted accordingly based on the response during the trial. We may choose a different array based on how they respond during that trial, but it's a very good question. Do either of you feel comfortable discussing the MRI conditionality of DRG stimulation?
So, I mean, I just came back from Aspen, and I talked to Abbott and to other companies, and basically the DRG is probably going to be MRI compatible because it is. It's just not approved. There's not enough studies. There's not enough talk, but it's going to be approved in the upcoming year or years, 2 years max. So as soon as this is done, there will be no restriction for the DRG. But it's true that at this time, some patients are asking, like, if I can't have an MRI, what's the issue? What should I do? But among I saw roughly 200 patients with DRG implants, and none of them had to be explanted for any MRI studies. So I think it's a fake issue. Ish.
I mean, MRI conditionality is an important aspect of any neuromodulation decision that we make with the patients. So from a current standpoint, the DRG Proclaim system is conditional for their 50 centimeter leads. They have 2 different lengths of leads. The longer leads are not MRI conditional currently. So they're 50 centimeter leads that are placed on label, which is T10 to S2, are MRI conditional. With that said, to go into MRI mode, it has to meet certain parameters. So if there's high impedances or fractures or something amiss with the lead themselves, the system won't necessarily go into MRI mode, and therefore the patient cannot necessarily have an MRI. And that conditionality issue lies with all companies and all neuromodulation device. It has to meet those certain criteria before it will be MRI conditional. Good question here is, let's look at you, Tom, here. So is SCS still the primary treatment for CRPS? And when could you use DRG stimulation over SCS for CRPS?
I think if you have a discrete, very identifiable dermatomal distribution, or in the distribution of a known peripheral nerve, I think that type of pain associated with CRPS would be more amenable to more amenable to DRG neuromodulation. Whereas conversely, if you had more diffuse pain, multiple areas of the body, crossing dermatomes, that potentially would be more amenable to traditional stimulation.
I would agree. Again, I think it depends. If we're talking about right upper extremity CRPS, honestly, in my practice, I would start with traditional stimulation before I move into DRG stimulation. However, if it is groin and below, if it's groin, hip, knee, foot, CRPS 1 or 2, I think DRG stimulation outcomes are far superior to dorsal column stimulation, and the data and the literature would support that. So other good questions. Unfortunately, we can't get to all of them. We're coming up close to our hour time frame. I'd like to ask both of you, are there any pearls that you would like to impart to those that are thinking about implementing DRG stimulation, are just starting out in their training, are interested in going to a national training if they're already out in practice. So any pearls that you would say to help them get through that initial decision on whether they should or should not take that step and utilize DRG stimulation in their practice? Let's start with you, Tom.
I think, like you alluded to, Dr. Wilson, having that skill set and having that additional modality just as a part of your toolbox, I think is a huge, it's a huge increase in the amount of relief and the amount of interventions that you're able to offer to your patients. So, you know, I've got a couple months left in training. I'm certainly gonna see if I can do more of these, just so that when I go out and practice by myself, I'm able to have that skill set and modality to implement if it's appropriate for the appropriate patient.
No, yeah, I agree with Tom. And I think if you want to do more, you can reach out to your rep. They will definitely help you and you know, send you towards like the educational committee of the industry that does that and provide great training. You can see and talk to a colleague who is doing a lot and, you know, shadow him or speak to him, or maybe if you're already in practice and you know someone who is putting DRG, having come with you to do a couple of DRGs with you and learn from him. But the reps are a good source. The cadaver course that you can have and do on the weekends all over the country are also great resource with most of the time amazing teachers. I learned a few tricks from Dr. Wilson myself.
And I'm sure Dr. Chapman is still a little frustrated with those techniques I taught you. So I really appreciate both of you coming on tonight, stepping up, stepping in. To be honest, you demonstrated that this is something that all of us can aspire to learn and know and implement. Personally, I've seen the successes of DRG stimulation in the right patient, and it really all depends on the patient selection. But I strongly believe it's something that needs to be, or at least should be considered to be a part of your practice, whether you're doing it personally or whether you recognize that it has value and it's something that you're comfortable referring on to academic or tertiary center for those patients that are just struggling. So with that, we are almost exactly at an hour, which seldom happens. Any parting words of advice from either of you?
Yeah, like you have to try DRG. If you're listening now and you haven't done it, you have to try it. It's essential. You need it.
I would echo that.
Thanks, Tom.
Well, thank you both, Tom. Thank you, Bart and Lily, and those behind the scenes that have helped this happen tonight. And for everybody who has logged in and tuned in tonight, we appreciate it. So with that, everybody have a good evening.
Thank you, Dr. Wilson.
Thanks very much.
Bye-bye. That's it, I guess.